Next, ventricular arrhythmia in patients with left ventricular assist device by Dr. Hempatpour.
Good morning, everyone. Happy Sunday. Thanks for being here. Well, they say no heart failure conference is completed without a EP talk, so here we go. All right. I'm here to present to you our experience with VT ablation in LVAD recipients. Well, in general, the published data, the literature, is very limited in this topic. The reason is because these patients are typically very sick. We lack standardized pathways to select these patients for treatment. There is inter-operator variability, and different centers have different protocols. So the slide that you see is what we have in the literature so far, just a few case reports. As you see in the fourth row, the number of patients vary between 3 to a maximum of 34, and these are all retrospective chart review studies. So this is a sample case series of our own center. These are 7 patients who were VAD recipient and developed VT afterwards. When I say VT, I mean VT storm. 3 or more sustained episodes per 24 hours. This is by definition, but in clinical practice, that means when your heart failure colleague calls you and says, nothing is working, no medicine is working, no ischemia, we have ruled out, the VAD cannula issues, volume status is okay. It's a busy slide, I apologize, but I pay your attention to probably column 5, which says VT occurrence post-VAD. This is one of the risk prognostications for the VT post-VAD. We divided into early VT and late VT. The patients who develop VT within 30 days of VAD implantation have a different prognosis compared to late onset VT. The early VTs also include peri-VAD VT, which means some patients do come with VT, receive the VAD, and continue to have the VT. And then the column before the last column, I'm sorry, the outcome column. So there are 3 possible outcomes. The best outcome when you take these patients to the lab is that after you ablate these patients, you cannot induce any VT, neither clinical nor a polymorphic non-clinical VT. So these patients have shown to have survival benefit. Second outcome is you cannot induce the clinical VT, but you can induce a polymorphic VT. These do almost as good as category 1. And number 3 is you bring them to the lab. No matter what you do, the clinical VT remains inducible. These people are typically patients who have epicardial circuits for their VT. Some initial stats in our limited case series. 3 patients had VT within 30 days post-VAD. This correlates with data from other centers. We had 1 bundle branch reentrant ventricular tachycardia. This is very important because this VT responds very well to ablation. We had 2 VTs from inflow cannula, which I'm going to explain a little bit about it. 4 patients had more than 1 ablation, roughly 60%. And survival above 1 year was 60% in our limited data. Again, timing distribution of 9 VTs out of the 7 patients. 2 had prior VT, 3 patients had VT within 30 days, and 4 had VT after 30 days. Another graph, which correlates with other centers, the horizontal axis is the month. So within the first month, 4 patients had ventricular tachycardia, and the rest of them were distributed with a little cluster towards, months, late months, which we've seen that with other centers. This is etiology of the VTs, bundle branch VT, which has great prognosis after ablation. Some VTs were related to the RV scar, which if it's not pure ARVD, that indicates extensive scarring. 2 patients had inflow cannula VT, which again, cannula probably was inserted in an area that was already anerolateral scar for my surgeon colleagues. And epicardial VTs, which are historically almost impossible or very difficult to treat after VAD, because accessing that epicardial space is difficult because of the adhesions. The rest of them, almost 50%, were pure endocardial scar. So this is a 59-year-old patient which we saw this January, day 13 post-LVAD. I don't get into the heart failure specifics, and I apologize, but I guarantee all these patients are taken to the lab after lots of conversations with our heart failure colleagues, making sure there's no ischemia, no VAD issue, no reversible cause, no volume issues. So this was his VT, incessant, required several shocks, 150 beats per minute. What stands out is that it's a left bundle branch pattern VT. So this is, I'm sorry again, it's in the busy slide, but I'm an EP, so I just had to throw it in there. The top rows show the surface EKG. The middle rows, or between the top and bottom rows, which have written CS next to them, they typically show the atrial activity. So you clearly see there is a dissociation between the atrial activity and the QRSs. Consider these P waves. The take-home point of this slide are these little blips that happen prior to each QRS. These blips are representation of the His bundle potential. This is almost pathognomonic of the bundle branch reentrant VT, because this pattern you can only see in sinus rhythm, typically, and in bundle branch VT. So this is how it works. Basically, it's a short circuit between the right bundle and left bundle. You may ask me that, why doesn't this happen more frequent? And it's only 10 to 15%. Because going back to physiology, these bundles can conduct electrical signals ultra fast, and it requires a lot of scarring to unilaterally slow down electrical conduction in one of them and permit a reentrant circuit. So this is what happened in the EP lab. This is again, it's not the fluoroscopic view, but it's almost the same. It's our 3D electroanatomical mapping. So this is the left ventricle, right ventricle. The yellow dots represent that little blip that I showed you. They are location of the His bundle. And the blue dots are where I ablated the right bundle, which is typically what we do for bundle branch reentry. Either ablate the right bundle or, less frequently, the left bundle branch and terminate the circuit. This is another view, I would call it like posterior left side of the same patient. This patient, so far, we saw him in clinic, EP clinic. There was no VT. If I have time, I would like to present one more case as well, quickly. This is a 63-year-old lady who presented 2 weeks post-VAD. She never left the hospital, obviously, 2 weeks, with incessant VT. The map on the left side is a voltage map. If you look at the scale, from purple, which is the healthiest signals above 1.5 millivolt, all the way down to the gray, which is the most dense scar. That's how we generate this map. You see a circle here, which represents the inflow cannula of the VAD. And this is a map generated during sinus rhythm. Typically, where we see crowding of the colors, that's the slow conduction zone, which correlates with the circuit of VT. In this instance, the scar map and activation map correlated, which is a good indication of the area to burn. So after we generate these maps, we induce VT, and burn it and make sure that we can terminate it during ablation, which is what happened in this next slide. You see in these two views, we ablated that channel, and VT was terminated. A couple of words on inflow cannula VT. Initially, when it was described, everyone thought this is the most common cause of VT post-LVAD, because that's the newest change that we made to that left ventricle. So it was reported at 64%. As time went by, the incidence is dropping, the true incidence of it, because it appears that it's not truly a separate entity. It's basically by inserting the cannula in an apical scar, you make it more possible for that substrate basically to induce the VT. So the theory now is that these are pre-existing scars, and they did have the potential to induce the VT. The only benefit of this diagnosis is that you localize your diagnosis to a smaller area, and which we saw in the previous slide, and so chances of success is a little higher. Challenges with successful ablation near cannula. There are some noises because of the cannula in our electroanatomical mapping. The sewing ring impedes adequate power delivery, and adhesions prevent epicardial access after VAD implant. So question, could empiric ablation at the time of LVAD implant reduce future VT burden? Some initial series have shown some promise in limited patients that they improve VT recurrence afterwards. And sometimes in the EP lab, there are no standardized therapies. We have to just open a surgery.com and look at the methods. So thank you very much. I take any questions.
Thank you very much. That's a very novel strategy to abate most questions. We have just a few minutes here.
A question for you. We've all seen patients that have refractory VT very early after implant. So in the patients with early VT arising from the inflow cannula, how soon do you feel it's safe to go in and do a study and ablate?
Very good question. So inflow cannula VT typically presents itself sooner compared to the scar VT. And you're right, within the 2 weeks, we see that. So it's a joint decision after ruling out everything, ischemia, the LVAD cannula irritating the septum. Typically 2 weeks is okay. If our, again, heart failure colleagues allow us, we feel safe to take the patient to the lab after 2 weeks. I think we've had instances that we even did it sooner, because if you mean the suture line, being a concern, it is very rare to have a problem in that area. We ablate in the right atrium all the time after, for example, bypass surgery, which you guys put the pump, cut the right atrial appendage, and we feel safe ablating around it, because nowadays we have, contact force, and we can limit our energy delivery. So the short answer would be 2 weeks sounds to be a safe timeline. And anytime one more thing I forgot to mention, that VT has characteristic of right bundle branch pattern and negative QRS in 2, 3, and AVF, versus the bundle branch one that I explained is typically a left bundle branch pattern VT.
Other questions, panel?
So I think that this is an entity that we face in our clinical practice in a frequent basis. If the heart failure team optimize the patient, optimize the filling pressures, electrolytes, suction of the, secondary to the cannula, you really, really need a very well-structured, very experienced EP service if you have an LVAD program. And we fortunately have one in our institution. Not because you don't have only early post-transplant arrhythmias, you have patients who, after 6 months, 1 year of implantation with frequent arrhythmias, also ventricular arrhythmias. And sometimes, recently we have 2 patients that we try to do everything that we can, ablation, medical therapy, and in the multidisciplinary rounds, we had the conclusion that we cannot offer any further therapies to this patient, and they have to be escalated in the transplant list. And the patient should be transplanted after that because we exhausted all the possibilities. But you need to have a very strong team.
Thank you very much. That's 100% true, but it can't be done only by EP service. We need you guys, you know, to let us basically give us the green light and say, you know, everything else is good to go. But yes, early VT, again, we talk about it a lot of times with Dr. Carr, with you guys, that should we take, should we not take, and we still have a lot of things to learn in this.
So I'd like to move on. I'd just make a comment that, in fact, of course, every case should be individualized. There's no nevers and there's no always, but the overwhelming data for these patients would suggest that even sustained intermittent VT, that there is no difference in mortality. It certainly affects their quality of life, but it makes you ponder, you know, is this a stopgap towards whatever should be the next step?
Well, the data on that, I agree, although not overwhelming, but it does show some mortality benefit. Not in that population, because we don't have good prospective clinical trials or enough number of patients, but in VT storm, we know that when someone comes with pure electrical VT storm, not due to acute ischemia, ablating that VT will have some survival benefit.
So in the VAD population, we do have that data through the registry for HeartMate 2 and the portion of HeartMate 3, which actually the paper was published at a Penn, which does not show a difference in mortality, only a difference in the quality of life. Now, things may have changed, and again, you know, not every patient fits into every study, and that was retrospective, but
yes, I agree with you, but there is no other option. Typically, when patient is in the electrical storm, we have this discussion with our colleagues that is it a mortality benefit? But when patient goes into VT back to back, basically there's no other option, just giving it a try.
I'm not underestimating how important even altering quality of life is. What I'm saying to the panel and the room is perhaps that if you have a patient like this, that the consideration for whether or not they should be accelerated towards a transplant should be at least considered.
Thank you.
Dr. Carr?
Yeah, we have to differentiate between VT ablation like he did and VT storm. VT storm is different. When you're having sustained VT, it will have a mortality benefit because your RV is going to tank. Even if your LV is there, if the patient's on VT for 24 hours, you know that this patient is not getting out of the ICU. I think that's the population he's talking about. But non-sustained VTs or even occasional sustained VTs, there will be no mortality benefit, clearly, and that you're right. And again, I don't know what the best strategy is going to be, like atrial fibrillation, like they do maze lines. Will it be useful to preempt them by making lines in the apex and the septum where it comes into contact and prevent it? Quality of life, we don't know. But VT storm will definitely have impact on mortality because this patient is going to die in the ICU. You won't be able to get him out of the ICU. That's the one we are talking about.
Yes, correct. VT storm. Those are the ones that have mortality.
Consistent VT, meaning these are like constantly the patient's heart rate is 180 and 200s.
I agree with Dr. Feldman. What we would do is just put our VAD in and list them for transplant if they are candidates, if they're not able to control. So.
And Dr. Carr, I think your point is very well taken as well. One of the things I did not hear, of course, this was, I'm not smart enough to be an electrophysiologist, but I didn't hear anything about hemodynamic instability in any of these patients. I did see that, in fact, several of them were on drugs that would actually be pro-arrhythmic.
So that is correct. Some of these patients, despite having LVAD, are hemodynamically unstable. So the strategy of ablation changes. We don't put them into VT to identify the circuit. We do what we call voltage mapping, just the picture that I showed you, and kind of empirically burn the areas that are potential channels for their future VT. If the patient is so unstable that we can't bring to the lab, then that's a different story. But the ones that are unstable during VT, we have strategies to work around it in the EP lab. It certainly puts them at higher risk, but we see them frequently.
Very eloquent, sir. Thank you. And
thank
Dr.
you
Carr, thank you for your comments as well.